Hello, everyone, and welcome to the Harm Reduction and Overdose Prevention and Response Training. My name is Krista Hales. I am a licensed alcohol and drug counselor in the state of Nevada, as well as an intern supervisor. Additionally, I hold several community positions, such as the Nevada Opioid Treatment Association president, There Is No Hero in Heroin board president, and so forth. I want to thank you all for joining me today. And let's delve into this harm reduction and overdose prevention training. Our objectives of this training are to define and understand harm reduction, recognize the signs and symptoms of an opiate overdose, learn how to respond to an overdose, and explain how to use naloxone to treat an opiate overdose. So the first part we're going to go over is harm reduction. You may ask why this is an important topic to teach at the same time as overdose prevention. Essentially, harm reduction is a way to meet individuals that have active use or active high-risk behaviors, meet them where they're at, and help provide them with some opportunity to make small changes in the meantime while they wait to determine if recovery is the right path for them. It helps them be safer in their use in the meantime, gets them connected to resources that they may need, which will actually in turn be able to help them make a better decision about their recovery. So it's like extremely important to cover harm reduction as well as overdose prevention so that we can make sure our community is safer as a whole. This first little video I'm going to show you is just a basic harm reduction video. It does have a statistic in here about the number of overdoses in a year time span. This video is about 5 years old, and so that number is a lot higher than the number you're going to see, which we will cover that when we go into the overdose prevention component of this training. So just feel free to pay attention to the rest of the harm reduction information that it gives you in this video.
Look, you're smart, you're cool, and you don't want to die, so you do things to reduce the harm of the risks you take. That's called harm reduction. It's all around us.
Taxi!
Harm reduction is common sense. It stops people from being injured and dying from things that are preventable. It saves lives, it saves money. It's smart. Here's a fact. Last year, 47,000 people died of drug overdoses in the United States. Because you're smart, you know these deaths are preventable. But here's something you may not know. Some kinds of prevention don't work.
Just say no. Who taught you how to do this? Any questions?
It's time to stop the drugs.
We've tried all these things, and still the number of people dying of overdoses continues to rise. But remember, you're smart. And because you're smart, you want to stop these preventable deaths. Do you know what is clinically proven to work? Harm reduction. You remember that, right?
Taxi!
Harm reduction works for people who use drugs. It knows that people aren't perfect, but they deserve every opportunity to be as safe as possible. It encourages people to get educated and connected with healthcare. Harm reduction provides access to naloxone, the drug that reverses overdoses. It provides people with sterile supplies to prevent the spread of HIV and viral hepatitis. And when harm reduction is implemented in its most effective form, it gives people who use drugs access to supervised injection facilities in order to provide life-saving interventions in the event of an overdose. In 102 supervised injection facilities worldwide, there's yet to be a single fatal overdose. With more than 47,000 overdose deaths each year, what are you waiting for? Support safer, healthier communities by supporting supervised injection facilities in your city today. Learn more at www.harmreductionactioncenter.org.
Okay, so to To define harm reduction, it is a set of practical strategies that reduces negative consequences associated with drug use and other risky behaviors. So we are also going to talk about sexual risk reduction as well. It is not just drug use. In relation to drug use, it incorporates everything on a spectrum from abstinence, managed use, safer use, everything in between. It meets people where they're at, but doesn't leave them there. So offers changes that they can implement now to make sure that they're using safely. And it applies a holistic approach. So it gives them the opportunity to get help and resources faster than if we completely dismiss their needs. There are 6 basic harm reduction principles. The very first one is health and dignity, which establishes quality of individual and community life and well-being, not necessarily cessation of all drug use as the criteria for a successful intervention and policy. For example, if a program implements HIV testing and treatment and they're able to get individuals into the care that they need, they're not focusing on whether or not they're still actively using drugs while they're in that program. The program is successful based on how many people they get into HIV care. Participant-centered services, which calls for non-judgmental, non-coercive provision of services and resources to people who use drugs in the communities in which they live in order to assist them in reducing attendant harm. So services are accessible and low threshold for people who use drugs. Abstinence is not a requirement for services. So an example of this would be the housing first model, where individuals would be able to get into stable housing regardless of their substance use. Participant involvement ensures that drug users and those with a history of drug use routinely have a real voice in the creation of programs and policies designed to serve them. The quote we use there is, "Nothing about us without us is ever for us." So making sure that those that are either in recovery or in active addiction get to have their voice heard regarding policy changes or programs that are implemented that could potentially affect them. The next principle is participant autonomy, which focuses on solutions that maintain autonomy and do not dissolve personal choice. So it affirms that drug users themselves are the primary agent of change, of reducing the harm of their drug use, and it seeks to empower those individuals to share these strategies. So the quote we always say here is, "You can lead a horse to water, but you can't make it drink." So ultimately, we can provide them with all of the resources in the world, and it would be their decision on whether they're going to make changes or not. Sociocultural factors recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both a person's vulnerability to and capacity for effectively dealing with drug-related harm. Basically, we are products of our environment. And then pragmatism and realism accepts that for better or worse, both legal and illegal drug use is part of our world, and we need to work together to minimize the harmful effects it has rather than simply ignoring that it exists. What harm reduction is not. So harm reduction does not mean that anything goes. We are not saying that this is a free-for-all. It does not enable drug use or high-risk behaviors. It ensures that individuals that are engaging in those behaviors are doing so safely. It doesn't condone, endorse, or encourage these behaviors. And it does not exclude or dismiss that abstinence is a viable option for some people. So abstinence is the ultimate goal of harm reduction, but harm reduction understands that some people may need to take baby steps to get to abstinence. The evidence that harm reduction works includes the reduction of bloodborne viruses such as HIV and Hep C. It also reduces the high-risk behaviors that transfer those diseases. With other community programs, it meets the needs of a more marginalized or vulnerable population that may not get into services otherwise. It noticeably reduces overdose deaths and preventing Hep C. Syringe exchange programs are extremely cost effective when you look at the lifetime cost of HIV or Hep C, and it offers an opportunity to advise and counsel on these high-risk behaviors. It gives individuals a chance to connect with counselors and peer support that they may not see otherwise or unless they get into treatment. You're able to have open, honest conversations about their high-risk behaviors and how they can be safer. So harm reduction is not just syringe exchange programs. It goes well beyond that. As I stated in the beginning of this training, it is everything from safer use to abstinence. So harm reduction includes detox and drug treatment programs. It includes the Hep A and Hep B vaccine, getting into HIV and Hep C services, safe injection sites, housing services, safer sex materials and education being distributed, overdose prevention, and prevention for non-injectors. Just because someone is not using or engaging in high-risk behaviors may not mean that someone near them is engaging in those behaviors, and they need to be just as well prepared to deal for those situations. Some basic harm reduction techniques that can be used for someone that's engaging in high-risk drug use or high-risk sexual behaviors is to never drink or use alone, as well as don't share supplies. So we don't want to drink or use alone because if an overdose or a medical emergency happens, there's no one there to respond. Additionally, we don't want to share supplies of any sort. So sharing syringes, cookers, water, cotton, anything like that, because sharing is how we pass those transmitted diseases, including abstinence days and schedules, meaning with this, instead of saying, I'm going to cut cold turkey tomorrow, we would look at it as reducing the number of days per use per week. And then as we achieve that goal, adding more abstinence days into schedule and seeing how long we can go before we get to complete abstinence. Buying only what you intend on using or drinking, because if you have more, most likely you're going to use more. Eating and staying hydrated, as well as not drinking or using when sleep deprived. If your body is significantly depleted of these resources, the substances are going to hit a lot harder and there's more risk of an overdose. Testing substances is extremely important right now, especially with fentanyl getting into almost every substance being used nowadays. I just watched the other day a news story about 3 individuals that had used cocaine that ended up passing away from fentanyl overdoses because of their cocaine being tainted. So obtaining fentanyl test strips and testing those substances, as well as if buying from a new dealer or the substance looks different than it normally does, using less than what you would normally use to ensure that there's not anything potentially mixed in with that substance. Having naloxone ready, this is important for individuals that are using, as well as those that may come in contact with individuals that are using. Naloxone is a life-saving reversal medication for an opioid overdose. And if we can save a life, we can potentially convince them to get into treatment. And then carrying condoms for sexual risk reduction, because condoms are one of the most effective birth control methods, as well as it's one of the only protective methods for sexually transmitted diseases. Now we're going to get into overdose prevention and naloxone administration. So overdose deaths have increased significantly over the last few years. In 1999, overdose deaths were at 16,849. And in 2020, we were at 94,134. So as you can see, this number has drastically increased. We know that COVID played a significant impact into the amount of overdoses in 2020 due to social isolation, individuals that were in recovery that relapse, or individuals that sought substances for the first time. And so now's the most important time in US history to be focusing on overdose prevention. So the 2020 numbers was the highest number of overdose deaths ever recorded in a 12-month period. Opioids are driving this epidemic, with roughly 2/3 of the deaths in 2020 being attributed to that, majority of those being fentanyl related. Drug overdose is now the leading cause of accidental death in the US. It surpasses motor vehicle accidents. It surpasses the peak of the AIDS epidemic. It surpasses the number of deaths in the Vietnam War. So this is an extremely important topic to cover. And there were double the amount of fentanyl related overdose deaths here in Clark County as of July of 2020. So between January 2020 and July of 2020, than there were in all of 2019. So as you can see, fentanyl is playing a significant impact and role in these fatal overdoses. This map right here shows you overdose death rates and how they change state by state from 2018 to 2019. That is the most recent chart we have for this. We don't have a 2020 chart yet, but it will be coming out soon. So all of the states that are in the extremely pale light purple there saw decreases. So as you can see, it was only 2. Most states are in that lighter blue, which means that their overdose death rates from 2018 and 2019 stayed about the same. And then the overdose death rates and the ones that are in that darker blue color increased. So a lot of West Coast, a lot of Southeast, so where we have a lot of international airports and borders and so forth. This chart right here shows you what overdoses we're seeing when we break down opioids in general. So starting in 1999, going up to 2019, that light green line shows you all opioids lumped together. The purple line shows you commonly prescribed opioids, such as our natural and semi-synthetics and methadone, which we're going to get into here in a little bit. The orange line is heroin overdoses, which peaked in 2016 and is starting to go down. And then the dark blue line is synthetic opioids, which majority of the time is fentanyl. And as you can see, that one is continuing to rise. So this is our latest data that came out from the CDC Overdose Data to Action Program that's monitoring overdoses. This came out in August of 2021. A suspected drug-related overdose or ED visits, so just emergency department visits in general, increased from June of this year to July. From June to July suspected opioid-related ED visits increased by 5%. Opioid prescription rates per 100 residents decreased by 5%, meaning we were seeing less opioid prescriptions written. And most often throughout this in 2021, July of 2021, most drug-related concerns in the ER were Caucasian males between the age of 25 and 34. So as you can see here, in July of 2020, 53% of the ED visits that were drug-related were males. 53.2% of them were Caucasian, and 23.4% of them were in that 25 to 34 range. This is specific to Nevada, these numbers right here. So overall in the US, I would assume that we'll probably see the same, but these are specific to Nevada. So hospital mandated drug overdose reporting for Nevada residents. So the blue line represents the overdoses that hospitals reported in 2018 throughout the whole state. The orange line represents 2019, the gray line represents 2020, and the yellow line represents 2021. So as you can see, in almost every month so far, the gray line was the highest, other than towards the end of 2020, we saw a dip there. So we'll see how many continue to be reported in 2021. So overdoses reported by hospitals of Nevada residents in July of 2021. So these are actual overdoses, not just ED visits. Again, 54% were male, 63.6% were Caucasian, and 95.9% reported being non-Hispanic. And then this is our fatal opioid overdose data for Nevada for 2019 through 2021. The blue line is 2019, the orange line is 2020, and the gray line is 2021. So as you can see, towards the end of 2020, those fatal overdoses began to increase and continued in 2021, but are now starting to drop in 2021. So now let's talk about opioids. So this picture on the left is the opium poppy plant, where we would get our natural or semi-synthetic opioids from. And the picture on the right is what we more commonly see as opioids today. Opioids are psychoactive substances that are derived from that poppy plant or synthetic analogs that are created in the lab. They act on our nervous system to relieve pain, and due to their pharmacological effects, opioids in high doses can cause respiratory depression or become fatal. So synthetic opioids would be tramadol, methadone, fentanyl. These are ones that are solely made in the lab and have nothing that come from the opioid poppy plant. Semi-synthetic, which are partially from the plant, partially made in a lab, are heroin, hydrocodone, oxycodone, hydromorphone, oxymorphone, buprenorphine, or more commonly known as Suboxone or Subutex. And then your natural opioids, which are solely from the plant, are morphine, codeine, and opium. How an overdose occurs. So opioids repress the urge to breathe. Breathing then stops and carbon dioxide levels increase in the body. Oxygen is our number one need. So once carbon dioxide levels start increasing, it's 4 minutes until brain death occurs. Our heart then stops, and then you have a fatal overdose. How do we tell if someone is overdosing versus being really high? If they're overdosing, they're going to have a choking or gurgling sound. It's sometimes called on the street as a death rattle, maybe sound like they're wheezing. They're going to be awake but unable to talk. They're going to have blue or grayish skin depending on their natural complexion. If they're of lighter complexion, their skin's going to appear blue, especially in their lips and fingertips. If they are of darker complexion, their skin is going to appear gray. They're going to be sweaty, have clammy skin. They're not going to respond to stimulation or a pain cue. What we call the pain cue is if you make a fist and you take your middle knuckles and either grind it into your sternum or directly under your nose. If someone is not overdosing, they're going to respond to that immediately because it does hurt. If they are overdosing, they will not respond to that. Their breathing is going to be very slow, irregular, or they may have a stopped or faint pulse. So those are going to be things that you can look out for. If they're just really high, they're going to be sleepy looking. They are going to be able to communicate verbally. It may just be slowed or slurred. They may be scratching, respond to stimulation like that pain cue, or if you yell at them or pinch them, they're going to respond. And their muscles are going to be really relaxed, but they're going to have regular breathing. What puts someone at risk for an overdose? So a tolerance shift is a massive overdose risk. This means if an individual was previously using, goes into a stable setting such as incarceration or inpatient treatment, and then comes out and tries to immediately use the same amount they were using before, that is going to put them at an overdose risk. Also, if they try to use more than they've ever used before, they're at an overdose risk. Mixing drugs. This is where we talk about uppers and downers. If you have an individual that is using two downers, such as opioids and alcohol or opioids and benzodiazepines like Xanax, that will repress their breathing too much that it'll slow their heart and cause an overdose. Also mixing an upper and a downer. So if you mix opioids with methamphetamines, or what is more commonly called speedballing, this will shock their system, and in turn, the body doesn't know how to respond to which substance and could cause an overdose. Physical health includes not only diagnosable conditions, so if an individual has hypertension or cancer, but it also includes things like stature. So an individual, a female that is 5'1", 100 pounds, is not going to be able to use the same amount of a substance as a male that is 6'7", 300 pounds. So taking things like that into account. Variation in strength and content. So again, we know that our drug supply right now is heavily tainted with fentanyl. So taking things into account as far as that goes, how much a substance may be cut with other substances. A switching route of administration. So someone that uses by injecting in the vein or muscle is a lot more at risk for an overdose than someone that uses orally. And then using alone, because again, if you're using alone, there's no one there to respond if an overdose happens. What not to do. So these are responses that we have commonly heard when conducting this training about what you should do if someone is overdosing, but these are 100% not the way you should respond. So you never want to leave the person alone, because if they come to, you need to explain to them what just happened. You also don't want them alone because it could become a fatal overdose very, very quickly. You do not want to put them in a bath because they are non-responsive. So putting them in a bath is not going to wake them up. They're potentially going to drown. Giving them something to drink, they're having difficulty breathing, so they could choke if you give them something to drink. You don't want to put ice down their pants, especially for males is where we hear this most often, is to either kick them in the groin or put ice down their pants. It's not going to shock them out of the overdose. It will actually do nothing to them. And then you don't want to inject them with anything. So we've heard salt water because the thought that it was similar to an IV fluids bag. It is not. We've heard cocaine because if they're on a downer, you need to hit them with an upper. That will not do anything. That will just shock their body even more. And then we've also heard milk because we've heard, oh, they're overdosing because they're vitamin deficient. Milk is only going to clog their veins and make blood flow even harder. So what is naloxone or Narcan? Naloxone is an opioid antagonist. It can reverse an opioid overdose. Essentially, it goes into the brain. It blocks opioids from attaching to the mu receptor sites and prevents that or reverses that overdose that may be occurring. It was actually patented in 1961. And for a very long time, it was only carried by EMS. But now in recent years, there's been more of a push for public to carry it because of the amount of overdoses that we're seeing. So how does naloxone exactly work? It has a stronger affinity to the opioid receptor sites. So if you look at that picture on the left-hand side there, those darker green little squiggly lightning bolt looking pictures are your mu receptor sites in your brain. The blue circles are opioids. Narcan, which is that green circle, comes in, knocks the opioids off of those receptor sites and clogs them so the opioids cannot reattach. It lasts about 30 to 90 minutes. So that is why it is crucial for EMS to be on the way if there is an overdose, because depending on how much opioids the person has in their system is when that Narcan wears off, they could go right back into that overdose. So you want to make sure that EMS is on their way and gets them checked out. And it starts to have an effect within 2 to 5 minutes of being administered. So it works extremely quickly when it is given to someone that is overdosing. It's important to know that naloxone only works on opioids. It does not work on cocaine, methamphetamines, Valium, Xanax, Spice, any other substance. It only works on opioids. So if all else fails, if you think someone is overdosing, it is better to administer it than to not, because if they have opioids on board, it could potentially save their life. If they do not have opioids on board, it will not have any effect on them whatsoever. There are 4 types of naloxone, and we'll go over all of them, especially the one that's more commonly distributed nowadays, but just so that you're able to operate any of the 4 if need be. So the Narcan nasal spray is the top left corner there. That is the most common one that is given out because it is the easiest to use. And we'll go over how to exactly use it here in a few slides. The top right is the Narcan Lure Lock. This one is not distributed as often anymore because it is a little bit cumbersome. You have to unhook colored pieces and snap it all together. And in the heat of the moment of an overdose, that could become a difficult task to complete. The bottom right picture is the intramuscular injection. Again, this isn't commonly distributed. You do have to pull the medication up in a syringe and then inject appropriately. So there's a few more steps to it. And then the bottom left is the Evzio auto injector. This one actually talks to you and walks you through how to do the administration. And so it's the most expensive of the 4, and it is the most rare to see. So our 3 steps to reverse an overdose, the 3 main things to remember are to 1, identify the overdose and check for a response, 2, call emergency medical help, and 3, start giving the naloxone nasal spray. The reason why we want to call EMS before we give the naloxone nasal spray is because you may only have so many doses on you, and you want EMS on the way with more naloxone in case that individual needs additional doses. So the very first step, breaking it down further, identifying that overdose and checking for a response. You're going to ask the person if he or she is okay, shout their name if you know it, shake their shoulders and firmly rub their chest, doing that pain cue. Or if it's middle of winter and they're wearing multiple layers of clothing, rub underneath their nose with your knuckles, and then check for those signs of an opioid overdose, such as the clammy skin, the color of their skin, their breathing patterns, and so forth. You're going to call for emergency medical help, get them there as soon as possible. You may need to move the person to the recovery position, which is on their side with their head elevated, so that if they vomit, they do not choke on it. And then every 2 to 3 minutes, you're going to start giving that naloxone. This is how you complete the lure lock administration. So you will pop off the yellow caps of the syringe piece. You'll pop off the red cap from the naloxone component. Then you're going to screw on the atomizer and screw in the naloxone and then push it up their nose. So quite a few steps there to just get 1 dose in their nostril. The nasal Narcan, which is the easiest to use, you're just going to make sure that the person is lying on their back with their head elevated. You're going to take the Narcan out of its package. There's no lid or anything on it. You're going to hold it just like that picture there on the left-hand side with your thumb on the plunger, your middle finger and your pointer finger on each side of the nozzle. Stick the nozzle up their nose, again, making sure that their heads tilt back. You do not need to depress the other nostril. It will absorb in the one that you put it into, and then just press that plunger down. That is 1 dose, and they are not reusable. So once you've done that, you will need additional doses, and that one can be thrown away. For the intramuscular, there on the left-hand side, you'll have to remove the naloxone cap. You're going to put the syringe into the, through the rubber stopper into the vial, pull up 1 milliliter, and then you're going to inject in one of the more meaty parts of the body, so upper arm or thigh muscles, and again, do it again every 2 to 3 minutes. And the Evzio will again talk to you. So you pull off the red safety tab, place it on their thigh, push it down, it counts down from 5, and then you're able to replace the cap. So aftercare, once someone's awoken from their overdose, you want to stay until help arrives. Do not leave them alone because again, that naloxone could quickly wear off and they could go back into their overdose depending on how much opioids they have in their system. That naloxone wears off after 30 to 90 minutes. So you want to let them know that they've overdosed, that EMS is on the way. Hopefully they're already there by that point, and they can evaluate the individual. But again, do not leave them alone. While you're waiting for EMS, just be aware that the person could become physically ill or vomit because they're going to be experiencing withdrawal symptoms. You just took all of the opioids off of their receptor sites, so they're going into immediate withdrawal when they wake up. They're going to be super agitated and upset, so you need to talk calmly with them. Please do not tell them to calm down because they're going to have an adverse response to that, but just let them know what happened and that EMS is on the way. And then there may be a rare occurrence. This has only happened in our older population, our elderly population. They may have a seizure, but this does not happen often at all. So this video is going to show you exactly how to administer the Narcan nasal spray, which is the easiest of the 4 to use.
Hi, I'm Allison, a pharmacist, and today I'd like to go over how to use your naloxone product. It can be really difficult in an emergency situation to remember everything that you may have learned about naloxone. So feel free to come back to this video from time to time to review the information here so that you can always be prepared in the event that you witness an opioid overdose. So you've called 911 and grabbed your naloxone. Now what? This is Narcan nasal spray. It comes in a box with 2 doses. You're going to take 1 dose out of the box, remove it from the packaging, and the applicator goes in 1 nostril, and you're going to depress the plunger with a quick, firm push. When putting in the applicator, you'll want to form a tight seal at the patient's nose so that the medication goes up into the sinuses and does not come down the face. And then with a quick, firm push, you're going to administer the medication. There's no need to depress the other nostril. You can leave it open. And if a second dose is needed, you will apply it in the other nostril than the one that the first dose was given in. And that's how you use the Narcan nasal spray.
Okay, so this link on the left is an naloxone map. It is universal. It is not just Nevada specific. So you're able to use that link to find where naloxone is available closest to you. However, majority of those are going to be pharmacies where you would have to pay for the medication. Here in Southern Nevada, we are distributing naloxone locally free of charge in numerous locations. So you can go to the pharmacy at the Southern Nevada Health District, any of the 3 Center for Behavioral Health locations in Southern Nevada. You can also go to Track B Exchange, the Syringe Exchange program to the storefront, or Foundation for Recovery. And all of these individuals will be able to give you naloxone kits for free. I want to thank you all for listening to the training to this point. If you have any questions, feel free to send me an email at either of these emails located below. The Center for Behavioral Health is my work email, or the There Is No Hero in Heroin Foundation. Additionally, if your naloxone expires and you need kits, please reach out to me. Or if you would like this training in person for your organization, you can reach out for those too. I want to thank you all again for listening, and I hope you all have a good day.